Hello, everybody. Welcome to our second DTx webinar. We are at 11 o'clock, so we're going to let some people file in while I do housekeeping notes, and then we'll turn over the floor to our speaker for today. So welcome. Today is the second DTx webinar in our 6-part series. And today is the presentation is Bridging the Gap, Digital Health Solutions in Treating and Managing Digital Health Solutions in Treating and Managing Substance Use Disorder. And our speaker is Hans Morefield. It is a free educational event brought to you by the Louisiana Department of Health, Office of Behavioral Health, Northeast Delta Human Services Authority, and Foundation for Wellness. It is accredited for 1 hour for ADRA, AMA, PRA Category 1 credits, LPC, and social workers. Full participation of this presentation is required to receive credit, and we monitor throughout the session. In 1 week, you'll receive an email from Foundation for Wellness with instructions on how to claim your credits and access your certificates. If you dialed in by phone, please email info@foundationforwellness.com, and in the email have the phone number that you dialed in with, as well as your first and last name, so you can count as being attended for this event. That does not count if you're using Zoom on your phone, just if you're dialing in using audio. Don't forget to register for our session 3 Digital Therapeutics webinar. It is going to be on May 8th, and then you can visit foundationforwellness.com/DTX to register for the next webinar. Hans Morefield has nothing to disclose, has disclosed that he is an employee and a shareholder of Chest Health. That is the only thing he has disclosed. A little bit about our speaker. He is the CEO of Chest Health, a New York-based technology company delivering an end-to-end platform for the addiction management lifecycle. After 6 years with Ernst Young's healthcare consulting practice, Morefield was an 11-year member of the leadership team at SCI Solutions, which grew from a startup to hundreds of health systems with patient access and care coordinating functionality. Morefield went on to lead the care coordination and population health business at Experian Health before assuming the CEO role at Chest Health in 2017. He is an expert and frequent speaker on the subject on emerging healthcare technologies, including care coordination, patient engagement, and digital therapy. He is a graduate and trustee of Kalamazoo College in Michigan. I do want to remind everyone that the Q&A feature and the chat feature is enabled. Please, throughout the presentation, ask questions. We will be monitoring throughout, and we can stop. He's going to stop and answer everyone's questions. So that is at the bottom of your screen for questions for our speaker. So I'm going to turn it over to our speaker, Mr. Hans.
Great. Ashley, thank you so much for the introduction. Very nice to meet all of you today virtually. I'm not going to see your face, but I would love to see your comments and your questions as we get into the discussion today. As Ashley said, my name's Hans Morefield. I'm the CEO of Chest Health, and I am excited today to talk to you about digital therapeutics and give you a perspective and a lesson that comes from, now 7 years of experience in this field. So let me just get my PowerPoint all set up. Great. Okay. So I think everyone can see my screen. Again, a little bit, I want to just reinforce something that Ashley said from a housekeeping perspective. I love questions. I love comments. I'm happy to answer a bunch at the end, but I also don't mind if people have questions and comments as we go through. I have a colleague on the Zoom call today, Meg Miller. She's going to be reading the Q&A as we go along. If she sees if someone posts something that's relevant to what we're addressing right then and there, she'll politely interrupt me. And being a New Yorker, I don't mind being interrupted. It feels natural to me. So a little bit, again, about the disclosures. I'm the CEO and part owner of Chest Health. We're happy to be in the digital therapeutic space. And today, this is the agenda that we've put together. So I'm going to provide a little bit of background about Chest and sort of my experience that makes it relevant to understanding, what I'm bringing today to educate you on. I'm going to review our educational objectives that include around addressing the gap in treatment, assessing DTx solutions, and the option of incorporating contingency management. And I look forward to a discussion and questions as we go through the presentation. And certainly we're going to leave some time at the end for your Q&A as we, from the bulk of the presentation. So a little bit of background. Little typo here for a second. Hold on. Okay, so what I wanted to reflect is Chess Health is a digital health company. We develop and deliver evidence-based solutions to support our partners. Partners are a wide variety of organizations that I'll describe in a moment, to reduce the personal and societal crisis of substance use disorder. What we're really well known for is our e-recovery solution, which includes this Connections app, which is all about supporting recovery every minute of every day. And again, we're not going to be talking about the Connections app today. We're going to be talking about digital therapeutics more broadly, but this is, part of the experience and perspective that I'm able to bring today and share with you, what we've learned and seen in the industry. Just one other comment. We think there's an opportunity to use technology to address substance use disorder more broadly. And at Chess Health, we have solutions to automate community prevention efforts. We call that e-prevention. We have a solution to help get people connected to treatment. Of course, that's a major issue that not enough Americans with substance use disorder are getting treatment. And that solution is called e-intervention. And then lastly, I know that all of you, and there are hundreds of you on the call today, represent a wide variety of organizations. Many of you are treatment providers in some form, clinicians, but we also know that there are individuals here today representing public sector organizations. And this conversation today is relevant to all of you. And we know that because we work with a broad variety of organizations, a lot of public sector, a lot of treatment providers, even Medicaid MCO plans. So we're really proud of that work, and that's why we welcome the opportunity to participate today to help educate the field in the ways technology can be supportive of the goals of the industry, the goals that we all have to, improve the outcomes and the lives, the quality of life of individuals and the individuals that they are surrounded by, their family, their coworkers, their friends that are affected by their substance use disorder. So that's just a little bit of background about Chess. I'm going to make one other little movement here. I'm going to change my screen just a little bit. Okay. So let's get into the educational part of this presentation. Today, we've got 3 learning objectives. One, we want you to understand the treatment gap in substance use disorder care in order to understand a key purpose for digital therapeutics. Secondly, we want you to help you to learn how to assess digital therapeutics for success in care delivery. And thirdly, we want to teach you a little bit, very briefly, about contingency management and its fit with digital therapeutics, but also, some perspective on, the appropriate fit with digital therapeutics. So those are our 3 key, objectives for today's learning session. And I'm going to start by just making clear sort of that we're all aligned with respect to the definition of digital therapeutics and Hans's little perspective on it. So the standard, because I know, again, many of you may have participated in lesson 1, and they're going to be, for our session 1. This is the second session in this series, and there are more sessions to come. So you're going to be hearing about digital therapeutics, potentially over the next few months. This is the standard definition. Digital therapeutics are evidence-based, clinically evaluated software and devices that can be used to treat an array of diseases and disorders. And the key word I would point out there is the word treat an array of diseases and disorders. Treat being the key word. What I wanted to add to the definition is that digital therapeutics may be used to complement non-digital treatment, so that they don't have to be limited to actual treatment. They can also be used to complement treatment. And that's, part of why, that is really relevant to the first element of our learning objective today. So again, Hans's definition, a digital therapeutic can be to treat or can be used to complement non-digital treatment. So again, in terms of our learning objectives, we're going to start by understanding the treatment gap with respect to substance use disorder. And so let me step you through that. So first of all, when we all talk about individuals getting substance use disorder, we all recognize it's not a come in, get one visit, and you're done. We understand that substance use disorder is the treatment of substance use disorder is a long process. 6, 12 months. It might start with residential treatment and then step down to partial hospitalization and IOP and then general outpatient, or, for individuals who are getting treatment for opioid use disorder with medication for opioid use disorder, it might just be largely outpatient treatment. Individuals starting on methadone or on buprenorphine, Suboxone, and getting regular counseling and treatment. And again, that treatment should be going on for months and even potentially years. And so you just hear like, oh, this individual's been in treatment going to be in treatment for months. And so I'm representing that here as one long bar, like this long stretch of treatment. But the truth is that there are a lot of gaps in that treatment. So an individual might be in treatment for months, but there are actually a lot of gaps. And this is a little, as we sort of zoom in, a little bit more explanation of what I mean by those gaps. And what I mean by that is that when an individual comes in for treatment and they've moved into, outpatient treatment, which again might be just a few weeks after they start treatment, or it might be how they start, they're going to come in for an individual session. They're going to potentially get some therapy. Maybe they'll get their meds renewed. Again, it depends on their treatment pathway, on the specifics of their treatment. But the key thing is, in outpatient treatment, they're there and then they walk out the door. And now this is when providers, this is when the public sector, this is when health plans worry about the individual that they care about. Is this individual going to return for their next visit? Because they've walked out the door, and if they're in weekly therapy at this point, it's 167 hours until their next provider visit. That's the gap in treatment. No one returns to use during their, clinic visit, during the 50 minutes or 60 minutes that they're, at their provider location. It's in the 167 hours in between that they're going to face inevitably some risk moments when they're triggered by something, they're struggling with cravings, they get into a spiral of negative thinking. And many of these risk moments, of course, will pass. And obviously the whole point of therapy is to help them learn skills, or the purpose of the medication is to reduce the cravings. But nonetheless, these risk moments will happen, and some of them may be severe, and that can lead to a return to use, and that could lead to recurrent return to use. And then you've got someone who's dropped out of treatment. And
Hans.
yeah.
I'm sorry. I did want to just interject. There's a Lavelia Moore who has her hand raised. So I wanted to make sure that that question could be maybe addressed if it was related to this specific section.
Sure. Was there a question or comment, Olivia?
Oh, it looks like the hand went down.
Okay.
All right.
Okay. No worries. So, so again, this is the gap in treatment. That's, when individuals are at risk. And the question is, what do people need during this time between visits? And if we think sort of broadly, and again, I'm stepping away from a technology perspective for a moment, but you're just sort of thinking, how do people get through this 167 hours? Well, ideally, they have engagement and distraction that keeps them busy and not dwelling on their thoughts, because their thoughts can turn negative. They ideally have engagement that avoids isolation. They have encouragement and motivation to maintain their recovery. They have reinforcement and practice of therapy and lessons and recovery skills. And if necessary, they have access to 24/7 support from a trusted human, individual when required. So generically, this is what people who, are in recovery ideally have access to between visits. If they have all of these things and they're in therapy, they're in a great place. And some of the ways traditionally individuals might get these things on the left would be by going to support meetings or being employed or going to school or volunteering. Again, they have positive, activities that are distracting and giving them focus and giving them purpose. Meetings and having people around them that understand and offer support can provide that encouragement and motivation. Meetings can provide reinforcement and practice of recovery skills, and maybe having a traditional sponsor, like as in an AA model, might be that critical 24/7 access that can be so valuable. And so, I'm sure all of you who've worked in this industry know individuals who, obviously have succeeded in recovery, and might have been because they had a lot of these things accessible to them, and these were things they were comfortable in using. The issue is, these traditional solutions are not available or applicable to everyone. And they've never been available and applicable to everyone. And even now, maybe even less so. And so some of the issues are that meetings are not accessible to everyone. Not everyone's got them, at a place that they can reach. They're not always available at times that they might be ready for them. We're seeing a lot of individuals struggling with social anxiety, who are introverted, who are very uncomfortable, and basically are saying to us and saying to their clinicians, I can't go to a meeting. I can't sit in a meeting in front of strangers and talk about myself. I'm not comfortable with that. Not everyone in recovery has work or other activities. Not everyone has a sponsor by any means. And obviously individuals can't just call their recovery coach or their counselor or their clinician 24 hours a day, 7 days a week. So what everyone needs, which is these items on the left, not everyone has access to. And actually, this is something I saw in our app yesterday, and I thought I'd share this as a little bit of, in a way, proof. This happens to be an individual. What you're seeing here is a screenshot of an individual who uses the alias name of Old Bulldog. So I'm not displaying any PHI here. And this person is celebrating in our app the fact that they achieved level 4, which is just a gamification level, something fun and an achievement. That means that they've been super active in the app and so forth. And the individual writes, along with sharing this, because they shared this with the whole community, it feels satisfying, which is great. And then he wrote, I think it's a he, I am very introverted, so it is a little weird posting anything about myself. This is definitely way out of my comfort zone. And so I want you to think about this individual for a moment. What you're hearing them say, what you're reading them say, is saying they're uncomfortable. They're a little uncomfortable even sharing, which by the way was completely optional to them, of course, this post that doesn't even identify them. But they're doing it. They're taking that step out of their comfort level and doing it because part of it is they know it's anonymous, right? Everyone just sees Old Bulldog. What I'm positive about is that this individual will not today, and would not a few weeks ago when they started using the app in the middle of March, go to a meeting. This is the kind of person who in the past has told us they can't go to in-person meetings. And so this is an example of someone who's using a digital therapeutic, who's saying, you know what, this I'm comfortable with because I'm the kind of person who's so introverted, I'm probably not the kind of person who's going to go to a meeting. And so just to sort of come back to this flow, we talked about the fact that individuals need support during this 167 hours, inevitably. Maybe not every day, maybe not every hour. And sometimes when you might be talking to individuals in your organization or elsewhere, and they say, well, aren't meetings or a coach or a sponsor or Facebook or friends and family, aren't those the tools to get people through these 167 hours? Then the answer is, well, they're not all 24/7. They're not all available in their area. They're not all available when needed. Facebook isn't anonymous, and friends and family may possibly not be helpful. And so that's a little bit of a setup and hopefully a helpful explanation to say a smartphone digital therapeutics can be perfect for this gap because it is 24/7. It should be trustworthy. It should be anonymous, and it should be supportive. And so this all goes back to, what I said earlier, which is I'm presenting a case where individuals are going to providers. They are getting in-person treatment, but a digital therapeutic can be great for this 167 hours in between to help them get to the next visit. So let me pause there for a moment. I'd love to see if maybe if someone could post in the chat or the Q&A, like that makes sense to me. Even some affirmation that like, yeah, I get that. Or obviously, if you've got any questions or comments about what I just went through, this is just sort of section 1 of what we're going to cover today. But it's the idea that a smart therapeutic can be, helpful for this gap in treatment. Okay, so I see one new message bubble. That does make sense. Thumbs up. Understand. Definitely a great idea for the gap in treatment. Thanks, LaShonda. Thanks, Olivia. Thanks, Amelia, Joanne. Thanks, Tyria, Dana, Susan, Candace. Okay, great.
And Hans, Peter did make a comment when you were going through that peer support, just reinforcing the importance of having that one-on-one support outside of those moments of being in person for treatment. So shout out to that statement too.
Okay. Danielle, thanks for that comment. Tricia, great. Okay. So, so we've covered, let me just close my chat window here. Okay. So we've covered the first learning session. I'm just going to check on our timing. I think we're in good shape. We've talked about the importance of the treatment gap. And so now I want to give you some tools on how to assess digital therapeutic solutions for success in care delivery. So what you're going to probably learn over the course of all of these sessions, and if you do research on the internet, there are many, possibly dozens of digital therapeutic options, addressing different diseases, different issues, and approaching them with different ways. And what I want to do today is help you, give you some pointers on how you would narrow down, the many or dozens down to a couple of solutions that you would closely assess. So this is sort of, some tools and some guidance to drive that funnel down to, okay, I know a few things I want to look at and assess and figure out how they can work for my organization. So first, there's some decisions you need to make. The first decision is, okay, what are we trying to do? Are we trying to address substance use disorder? Are we trying to address mental health? By the way, there are digital therapeutics for weight loss and digital therapeutics for other diseases. And today I think we're focused on behavioral health and substance use disorder, but in a way, part of it is to first decide on that disease scope because there are a really broad range of digital therapeutics. The second thing is, what's our goal for a digital therapeutic? Are we looking for something to deliver treatment, or are we looking for something to complement treatment? And again, that goes back to what we just discussed with the, in the previous slides. Are individuals still coming in person for treatment and looking for support in between? Or are we looking for a solution that's an alternative to in-person treatment altogether? And that also ties into the third question, which is a really important one. A third important decision is, how will it be introduced? How will people learn about this? How will they get this digital therapeutic? And in a way, the key sub-question is, what will the role of providers be? And the reason, what I want to make clear is that these first two questions are really interrelated. Because if the goal is, hey, I'm a county, I'm a state, I'm a public entity, I'm a health plan, and I want to get digital therapeutics into the hands of individuals in my community or members of my health plan, and I want the digital therapeutic to deliver treatment and to complement treatment, to deliver treatment, then what you're saying is the role is going to be to replace, is an alternative to the providers in the community, in which case the role of the providers in the community is going to be zero, right? The providers aren't involved because this is an alternative to in-person providers. That's if the digital therapeutic is to deliver treatment. So the point is, these are interrelated. If you selected DTx to deliver treatment, then you may be competing with providers, in which case providers may not support the effort. So again, if you're a public sector agency and you're the, Department of Human Services or a county Department of Health, and you're thinking, what can I do in my community? If you're going to use a tool that's in a replacement to providers, you're probably not going to get the support of providers in your community to get it out there. However, if you choose a tool to complement treatment, to address that gap, then you should find that providers will see value in being involved because it will help them. And again, many of you on the call today may be providers and probably are providers. And then you'd understand that, a digital therapeutic that delivers treatment could be good for the individuals you can't reach, but it's not necessarily helpful for the people who you are treating in person. What you want, in all likelihood, would be a solution that complements treatment, that's there for individuals between visits because it will help them. So again, maybe I'll pause in a few minutes and see if there's some questions and if this makes sense. But again, these are just decisions you're going to make. And again, there are hundreds of you on the call today, and so there are a wide variety of perspectives you may bring. But those two questions are really important to decide. Then, of course, there's the question of how much can we spend per patient? How much money do we have? Do we have, $10 per month per patient, tens of dollars per month, or do we have hundreds of dollars, per patient per month to spend? And by the way, this also comes back to what's the purpose? Because if the purpose is delivering treatment, well, then it could cost hundreds of dollars per month for a digital therapeutic. But if you're looking for something that's going to complement treatment, it's typically going to be a lot less. So obviously, cost is always a consideration, and cost ties back to what the goal is, delivering treatment or complementing treatment. And then lastly, what's my appetite for project risk? This is an emerging field. There have been companies who have been in the digital therapeutic space for a number of years and evidence-based and so forth, and there are new ones coming every day. And so one of the things you have to decide is like, hey, do I want to go, anyway, just as what's my appetite for project risk? Do I want to work with a brand new company in the field, or how proven do they need to be? So these first decisions will help you get a short list to choose from. And then you need to go through sort of the short list. And now you're going to be looking at things like, okay, what's the actual functionality and evidence of the couple of vendors I'm looking at, or the couple of solutions? How does it work? And does it work? And I think a really important question is the solution all digital, or is it digital plus human? Again, that's there's some differences there, and different solutions, across, substance use and mental health approach that differently. Obviously, it's also it's not just about the functionality, but also, will it really work? Will my patients find it easy to use? And will I be able to get my patients on the app? And so we call that ease of use and ease of onboarding. And your patients. And so make sure you're looking for solutions that have worked with, your patient population in the past. It's also very important to ensure that your data is going to be secure. that you have the ownership of the data, that your data is not going to be misused. There's something called high trust certification, which is sort of like the top level in terms of if an organization has high trust certification, then your IT team is probably going to say, yeah, that's a safe and secure vendor to work with. And then lastly, we would encourage, always assess experience. Don't be the first person to ever work with someone. They could be pretty new. Maybe they only have a few customers, but definitely check references. So let me just, got one more slide, and then I'll pause again and see if there's some questions or comments. And I think there's one thing in the QA. But what I wanted to do was come back to this page from before. So remember before I said, what are the things that individuals need, between treatment visits, generically, right? And they need engagement and distraction to keep them busy and not dwelling on their negative thought. They need engagement that avoids isolation and reinforcement of coping skills and so forth. And so my view on key functionality in a digital therapeutic that's designed to complement treatment is that you generally need three things. That a successful solution, that's addressing this gap needs functionality for engagement and distraction that could include discussion forums for connecting with others, access to readings, videos, podcasts, content, that just basically gives them both an ability to learn, but also just something to do. Access to support meetings provides engagement and distraction, daily activities, reminders, thoughts of the day, those build up motivation, and that this kind of functionality can first have the effect of reducing risk moments. That the more people have positive engagement, the less lonely they feel, the less time they have to get into negative thinking. That results in some fewer risk moments that individuals will have. But secondly, we're never going to say that we can, that digital therapeutics will eliminate risk moments. Individuals are always going to have risk moments in recovery. Hopefully they don't have them as often, but they're going to have them. And so then what's important is that from their treatment, from their therapy, they're learning self-care skills, and that the digital therapeutic is helping to reinforce and remind them, and in a way, even practice them, so that individuals have better self-care skills because of the digital therapeutic in order to manage the risk moments that they will inevitably have. But my last view on key functionality is that at the end of the day, we also know that as good as any digital therapeutic might be, there are going to be times when people just need to talk to a human, and they need 24/7, crisis support available to them when they can't self-care through a risk moment. So again, this is sort of my perspective on some of the key functionality if you're addressing that first goal of supporting individuals in a gap in treatment. So that was a little bit of a primer on how to assess DTx Solutions for success in care delivery. And let me just pause and see if there are any questions or comments from that second section.
You do have a Q&A, but I did want to call out, there were a couple comments made early. Susan DuPont said that many people in rural areas do not have access to support group either, so this is a benefit there. And Tamula Pinto said, I've always felt someone's mobile phone is a great way to bridge the gap, so I love to see this, all the ways a person can interact and get support. Peter Rush, or Rash, I'm sorry if I'm Rashke maybe, apologize if I'm saying that wrong, did have something in the Q&A. Are you able to access that, Hans?
Yeah. Happy to. Yep. So how do we reach people suffering from OUD and SUD who live in rurals and do not have access to internet or good cell phone service, but need digital therapeutics for certain reasons, such as anxiety? Peter, I think that the comment is, unfortunately, digital therapeutics generally all require access to the internet. So it's, not an option if they don't have it. I think the only comment I would make is in, even 7 years ago when I joined Chess, we would get this kind of question. And even then we were, surprised to learn how individuals, found access, how they discovered that every McDonald's has, free Wi-Fi, or they could go to the library and so forth. And certainly 7 years later, and I think COVID showed that a lot of individuals, the vast majority of individuals, do have access to a smartphone and do have access to the internet service. And again, I'm not saying everybody, and we wish it were everybody, and there are free phones available to everybody, but I'll mention, and once a week, every late January, I volunteer in a local emergency homeless shelter, because it's sort of, there are different churches that take turns hosting an overnight shelter for, local men, most of whom, probably have a substance use disorder, but not necessarily. But anyway, the little point I wanted to share, the little anecdote I wanted to share is when those individuals arrive at the shelter every night at 8:30, and they're about to eat some food and get a meal and a place to sleep overnight, at least half of them, almost one of their first activities is to go plug in their smartphone. And so we see a lot of evidence that even individuals who struggle with housing maintain access to a smartphone. It's become such a critical part of their life. So again, unfortunately, Peter, there's no way for a digital therapeutic to help someone who doesn't have internet access. But we do see a lot of ways that individuals can get access to a phone, and a lot of places, even in rural areas, where they can get access to Wi-Fi. Great. So hope that answered your question as best I could, Peter. So the last thing I want to do is talk about contingency management and its fit with digital therapeutics. And so maybe I guess I won't, I was going to ask, like, how many of you are familiar with contingency management? And maybe if you just post in the chat if you are familiar. Okay, or raise your hand. Lolita raised her hand. Great. So contingency management is a term that describes a treatment approach that gives immediate rewards for desired changes in behavior. And basically the principle is that if a good behavior is rewarded, it's more likely to be repeated. And that's sort of the overall approach. And many years ago, people started, researchers started testing this approach with individuals with a substance use disorder, which was to say, listen, as part of our treatment, let's actually reward them for positive behaviors. Because if we reward them enough times and they learn that, there's this early incentive and meaningful incentive that actually, engages their brain in a way that, drives the reward satisfaction, that the pursuit of the reward will help them learn the behaviors that will then make the positive behaviors for their recovery more automatic for them, and in the future won't depend on a reward. And so contingency management is this approach of rewarding, and often it's things like rewarding individuals for negative urine drug screens. That is, using rewards like that works that the individuals who get rewards like that have better long-term outcomes. And the last comment I'll make about this is that this has been particularly useful for treatment of stimulant use disorder for individuals who are, perhaps have an addiction to methamphetamine. They have methamphetamine use disorder because there isn't a medication for methamphetamine use disorder. And so this is one of the only evidence-based approaches to addressing methamphetamine use disorder. So there's a lot of support from SAMHSA, and there are a lot of other agencies and some states who are getting Medicaid approval to use contingency management to treat stimulant use disorder, and often more broadly, at least, opioid use disorder as well. So that's what contingency management is. And this isn't today a whole learning session about contingency management, but what I want to do is sort of explain how digital therapeutics plays into this, and also why, and some caution points around digital therapeutics and contingency management. So first, a couple of the quick best practices related to contingency management. First is, it's of course, if you're going to give someone a reward, make sure you reward for exactly what the desired behavior is. What is it that you really want them to hardwire into their brain, so that's going to be, most beneficial to their successful treatment and recovery. Secondly, you want, whatever the reward that you give them has to be really meaningful to them. Otherwise, it's not going to have literally the effect on their brain that you want them to. And some organizations use like a pantry of goods. Hey, go into the closet, grab something, and, as your reward for, a negative urine drug screen, for example. And the best practice is don't use goods. Don't use shampoo, don't use headphones, don't use a couple of different store gift cards. The best thing is to give them cash or a digital equivalent of cash, because that's going to drive more reward appreciation and reward value to the individual. That's going to have a better effect on their brain. Thirdly, design a long program. You can't just reward them once or twice, because that's not going to have the long-term effect that's needed. And the last thing is, you've got to deliver the reward as soon as possible after it is earned. If the idea is, hey, you're going to earn a reward and then next week we're going to give you a gift card based upon your urine drug screen this week, that's not going to have, again, the desired effect that like, wow, this was great. I'm so excited. I got this reward. Yay, this just happened to me. So those are some of the best practices. And then the challenge that a lot of providers have is that this all sounds good, but it's a mess to handle cash. It ends up being a lot of work for training and for staff to administer. There can be problems and errors. Of course, everything needs to be tracked, especially if you're using cash or, some kind of cash equivalents or gift cards. Everyone's going to want an audit trail. And if you're not using cash, well, then someone's got to go out and like buy this inventory of goods constantly and replenish it and make sure there's a broad amount. And that just becomes more work. And so this is where digital therapeutics have come in. A lot of people have said, oh, these kinds of issues can be addressed if I'm using a digital therapeutics that has the contingency management built into it. Because maybe it's an app with a debit Visa card, and then I don't have to manage cash, and maybe the rewards are delivered here, so my staff's not involved. And then because it's programmed into the app, there are no issues. And everything that happens in the app, it's all automatically created as audit trail. And so, boy, if I have an app with contingency management, then all my problems are solved. And so that can be a perspective, and in a way that can be true. But what I also wanted to do today was to say, and I gotta, there are some downsides to digital therapeutics with contingency management. So a moment ago, it was sort of like, oh, it sounds good. It sounds like it, software addresses all of the problems, but there are some downsides. And so let me step you through them. First, and maybe this goes back to Peter's comment, right? If the only way to use contingency management is through an app, then what about the patients who don't have a smartphone or they don't want to use an app? And that's really fair. And like we just said, there are obviously always going to be some individuals for different reasons don't have a phone now, or they had a phone, they don't have a phone continually, or they may not want to use this particular app. And then all of a sudden you've got a contingency management program that's only helping individuals who have an app. And I think we all want to help everyone. So my recommendation would be, if you're looking to do contingency management, look for solutions that support contingency management for everyone and isn't dependent on the app. The second thing is, if your digital therapeutic or app incorporates CM for all patients, in all cases, it's going to be really expensive. So again, contingency management might be something you're really interested in doing, or you think would be nice to do. But if the digital therapeutic that you go through a selection process only incorporates contingency management, that like requires it, then just be prepared that that digital therapeutic is going to be pretty expensive, because it's going to include the cost of all of those rewards. And so our recommendation there is, again, maybe look for digital therapeutics that might support contingency management, but don't make it a requirement if you can't afford it. And then a last little, insider baseball. If there's an app that says, you pay us one price and your clients or patients can earn a reward, and that's sort of optional, and it's all built into the price, then one of the things that's happening is you may be paying for rewards, because of course you in a way have to pay for the reward, or the grant that you get has to pay for the reward. But if your individuals don't earn the reward, well, who's keeping the difference? And so just a little question that you sort of need to look at as you explore contingency management. And then lastly, maybe a key question is that sometimes if the only thing the app does is contingency, is the reason people use the app because of the rewards, or do people use the app because the app actually helps them? And so a DTx, my bottom line is a DTx, a digital therapeutic that requires the use of rewards, has downside. You might want to separate the digital therapeutics from the contingency management, or find a platform that has it sort of optionally, and can also, do contingency management for individuals who don't have a digital therapeutic. So that was my little bit of a learning about contingency management and its fit with digital therapeutics. So we've covered these 3 learning session objectives today, and I would, welcome some feedback on whether this was helpful, and I would love some more Q&A. And so we've got, we're here to the discussion slide, and, please post some questions in the Q&A or in the chat, and I'll take a look at them and answer them as they come in, or I'd welcome just some comments. Peter, I just want to comment. I see Peter's comment here. Thanks for it, which says age can be a factor. A lot of older individuals seem to be leery of new apps. They do not understand or know well. Peter, again, I'm not necessarily arguing that isn't true. I would at the same time say we actually have a lot of experience with older individuals seeing a lot of benefit of the app. And so it can be a little bit surprising, but it's also really important that apps be really accessible to people, and that they don't have to be tech experts and super tech savvy. And so age certainly is a factor also in sort of adoption and user experience. Chantel, Jessica, thanks for the feedback. Angela, any questions? Anyone else ask? Thanks for the question. Is there any data yet to show how using the app has led to positive outcomes? So Lindsay, I wanted to be careful today not to really talk about the CHESS app, because this is supposed to be a general session. And then Andrella, in a moment, I'm gonna comment on what you said. But the answer is yes, there is a lot of data that digital therapeutics are effective. And in particular, I'll share with you, since you're asking, our app has shown a couple of different points. One is the state of Oklahoma sponsors our app statewide. They found that the individuals who used our app stayed in outpatient treatment 37 more days on average. They also returned to a higher level of care at a 24% lower rate. We've had treatment providers that have measured that individuals who use the app, complete like IOP at a 28% higher rate. So those are some of the benefits. And then Andrella, again, you said about a third of my clients are homeless and have lost phones. I understand, Andrella. But my comment would be, there's half your clients probably who, from your answers, do have a phone. And again, this may not be something that unfortunately is available to everyone if they're having trouble with a smartphone, but I wouldn't, discourage consideration of it if it can achieve and help tens or hundreds of individuals in the meantime. Carol, thanks for the comments. JC, thanks. Carla, thank you. Any other questions or comments? And otherwise we'll bring this to an end. A few more comments down there. Yes, and Janine Fernandez, that's absolutely true. There are virtual AA meetings throughout the world daily via Zoom. We love in-person AA meetings. We love virtual meetings of any type. We run some through our own app. And again, there are other ways than just an app to get support, including in-person meetings and all of those other resources. So Peter, the best way to encourage individuals to use a digital therapy is if their provider is the one who's saying, hey, this is a great solution, or if they hear it from their peers. And typically what we see, and that's why we also think that, providers or agencies that are supporting individuals, if you've got a relationship, your clinicians have relationships with individuals, they're the best person to advocate for it or have it discussed in a group setting and have other peers. Kendra, thank you for the comments. And maybe with that, thank you, Dana.
A lot of good comments from our attendees. Any other quick questions that what we have for our speaker? You can drop them in the chat. He will be sharing the PowerPoint presentation with everybody, so I will send a PDF of that after the event. Thank you. This was helpful. Yeah, so thank you so much for the comments, everybody. I'm sure this was very informative. Our second presentation in our 6-part series. So our next one is going to be in May. Please visit foundationforwellness.com/DTx, and you can register for the upcoming webinars on there. It's 6 parts. So we did 2. We have 4 more left. Thank you so much, Hans. Thank you so much, Meg, for being here and sharing all your expertise with our audience. We truly appreciate it. Thank you, everyone, for attending and spending your morning with us.
Great.
Thank y'all.
Bye, everybody.
Bye.